and our distinguished panelists. We're so happy to have you this morning. We will be recording this session, and we will have it available on the COVID-19 website for 10 days. And the reason only 10 days is we know the information changes very rapidly. So we're in for a wonderful learning experience this morning with our three distinguished guests, and they represent some very diverse areas in the health arena. I'm Carol Winchell, the Executive Director of Human Resources at the college, and I'm pleased to meet via Zoom Dr. Brookmyer, Dr. Casiano, and Dr. Pittman as our distinguished panelists. In Maryland, they say that our economy does so well because of the eds, feds, and meds. Well, it looks like we have all three represented here today. We're fortunate to have one of the best healthcare systems in the country, and the Frederick Health Hospital Center is part of that enterprise, providing outstanding medical care to this area. Dr. Barbara Brookmyer, if you'll wave to us, Barbara, is the health officer for the Frederick County Department of Health. She received her BS in toxicology from the Philadelphia College of Pharmacy and Science, now known as the University of Sciences, Philadelphia, and her master's in public health from Johns Hopkins University. She also has completed her residency training in family medicine at the Ventura County Medical Center. Her office has been leading weekly COVID-19 updates for partners, for which our Teresa Ceballos attends and provides that information to us. Dr. Manny Casiano is the Senior Vice President of Population Health and the Chief Medical Officer for the Frederick Regional Health System, Frederick Health Hospital, those folks right next door to us, property line. He received his BS in biology from MIT, his MD from New York University, and his MBA from Hood College, yes, and he currently serves on the Hood Board of Associates. Dr. Phillip Pittman is the Chief Department of Clinical Research at USAMRIID, and USAMRIID's a very important partner at Hood College. As we know, USAMRIID is a major research center at Fort Detrick. He received his BS in biology from Jackson State University, his MD and his master's in public health from Harvard Medical School and the School of Public Health. He currently serves on the Hood College Board of Trustees, and we're glad to welcome him as well to this important session today. I want to express our sincere thanks for your participation on this important topic, the truth about COVID-19. And of course, that's as we know it as 10:04 today. And now I turn the meeting over to our moderator, our own Dr. Linda Kennedy, Assistant Professor of Nursing and the Chair of the Hood College Nursing Department Program. And Linda, the panel is all yours.
All right, thanks, Carol. Welcome, everybody. So what we're going to do is start off with each of our panelists giving us about a 5-minute or so glimpse of their perspective of the COVID-19 pandemic. And then we have a plethora of questions that have been sent in that we'll get through, maybe not all. And you'll also have an opportunity as we're talking, if you have a question you'd like to be answered, just type it into the chat room, okay? It's on your right-hand side or on the bottom where it says chat. And then once you enter it, hit the return key and then it'll show up for us all to see, and then I'll moderate those questions. So let's get started with our panelists. And Dr. Brookmyer, let's have you start our session.
Oh, well, thank you. And I will attempt to share my screen here so that, there we go. I will do a slide presentation for us. I think, double click, there we go. And
there you go.
There we go. And one more click, there we go. So let's see. I'm gonna try to move all of you off to the side there. Okay, well, thank you. I so much appreciate the opportunity to talk with all of you, and this is part of an ongoing dialogue. Hood College has just been a terrific partner all along. Back when we started in January, I think I had already started conversations then, Teresa. We are currently at the health department in our 24th operational period, and our operational periods are weeks. So we've been at this for over 24 weeks now. And I realize all of you have received lots of information. It's pretty difficult to not hear some information every day in the media about COVID. I do note that today, Frederick News posts top 5 stories that they send out an email about. None of them were COVID related. So this might be the first day. So going back the history, so, at least what's been documented for the US, dating back to January 20th for the first case, and then several weeks later, the first death. And then in Maryland, that wasn't until March 5th for the first case. And in Frederick County, I will remember our first case was March 16th. We knew it was only a matter of time. And then unfortunately, our first death was, again, a couple weeks after that. You'll notice sort of that spacing is kind of consistent there between the cases and the deaths. And then when we look at the number of cases, we see that in the US, we have reached over 3.4 million, and we make up about a quarter of the world's cases so far. And in the trends in the US, states that had not had a prior peak to speak of are now accelerating their numbers of cases and appearing to peak. You never know when the peak has ended until you start to go on the downside of that slope. And in Maryland did have an acceleration phase and then a deceleration phase. So we would describe that as Maryland's first peak. And that was in May. It's from looking at the data though, in Maryland, the cases are starting to increase again on the Eastern Shore and around the Baltimore metro area. A little less so in the DC metro area of Prince George's County and Montgomery County, where they had actually been the counties that had had the highest cases before relative to the other Maryland jurisdictions. And Frederick County, we've had a relatively low positivity rate all along. And in fact, one day last week, we had the lowest positivity rate, but that was only for one day. And that's using a 7-day rolling average for the positivity rate. So we are starting to see some concerning trends in Frederick County. But whether it's just a temporary blip is hard to say, but we definitely know people are getting out and about more. And here is, and I'll try to move this over a little bit more so you can see there the cases and the deaths, and you can see where we had our peak cases in Maryland. And that was in that late April, early May time period, and the deaths also trended along with the cases. And when we look at Frederick County now, you can see our cases. We were, once we started having cases, we were pretty high and stayed rather high. And now we've trailed off, thankfully. And then with deaths, it's followed more of that pattern in the state in terms of the deaths. And so when we look at our current trends, we have definitely seen a change in the demographics week by week as the outbreak has continued. And so while our cases started out as older, and certainly our deaths started out as older, with over 86% of the deaths for a long time being associated with long-term care facilities. But our cases now are trending on the younger side, so definitely folks under 40, many folks under 30s. And the deaths are not, the age of the deaths hasn't trended younger, but the cases certainly have. And let's see, and we have had I wanted to point out that we've had no new COVID-19 deaths in June. And, when we look at the measures that we have to reduce the potential for transmission, and I think I'd like to step back a little bit here and say that, when we're looking at an infectious disease, control of the infectious disease can be challenging. And this novel coronavirus is particularly challenging. So I still at times refer to it as the novel coronavirus, novel meaning it's new to humans. And since it's new to humans, we don't have the benefit of having an immune system that is already armed with the appropriate antibodies and other parts of the immune system to immediately detect and immediately take care of that invading virus, to prevent that virus from multiplying and becoming an infection throughout our body. And since it's a novel coronavirus, that means we're all susceptible. So early on, we had hoped that as time went on and people became infected, we hoped that when people became infected, their bodies would mount an immune response, and that immune response would be to make antibodies and other parts of the immune system that would then be effective when an individual encounters the virus again. Unfortunately, and I believe that our other panelists will speak a little bit more about that, what concerns me from the public health perspective is that I'm not as confident anymore that people, once infected, will develop an effective immune response against subsequent exposures, and that the duration of any protection is going to be much shorter. Because when we look at trying to get a virus to extinguish in the population, one way is if everybody has protection, rather whether that's immune system, antibodies, and other components of the system being developed based on prior infection, or whether that's based on vaccination. And then if enough people in the community have those protections against an infection, then the infections can tend to, die out, go away, not spread. And so I am concerned with that. So since we don't have a vaccine that's available right now, and because it's really part of active research right now, whether people who, once they have become infected once, are they protected against subsequent ones? It makes it very important to go back to the standard public health actions to try to control the spread. And that's contact tracing. We do contact tracing all the time, long before COVID. So we've really needed to ramp up, though, our contact tracing and train lots of new people how to do it. And contact tracing is basically identify somebody who's been infected. Once you've identified a case, then you ask that case, where all had they been? Who might they have come in contact with the idea of informing those contacts of their potential exposure and advising them how to reduce the potential for them to spread it to other people. And so the state has a system called COVID Link, and they are the call center. The folks at COVID Link are making most of the calls in Frederick County. And at least the calls for people who are English speaking and Spanish speaking and other languages that we handle here at the health department. And if they're having difficulty reaching people, we also make those calls. And so they contact the cases, and then they try to identify who the contacts might be and follow up with those. Now, I would say that our ability to identify any contacts is based on the information that the cases tell us. And many cases have many interests in not sharing where they've been and who they've been with. For many people, it is employment, where they don't want their employer to know that they've tested positive because there are repercussions financially, as well as some significant stigma that I've heard from some employees. So we have many testing locations. I'd be happy to talk later about what is the value of testing and when is testing more helpful than not. And you can go to our website to find out where we have some recurring public clinics. Let's say from the health department, we are focusing our limited resources on persons who aren't able to access the other locations that are available or have difficulty accessing it, whether it's the time of the day that they're offered or whether there are some other reasons why people have some discomfort or inability to access those other locations. So we're trying to reach the historically less connected folks to the healthcare system. And but we've designed them to be low, no barrier clinics. So we haven't required people to make appointments. We haven't required people to come with a doctor's prescription, and we haven't required people to have a vehicle. And we also aren't requiring people to have insurance or charging them. So I know that there are many more questions. There's so much here to talk about. I will stop sharing and look forward to having more of a discussion so that we have
Great.
more picture.
Thank you so much. Let's move to Dr. Casiano now and get his opening remarks. And recall, he is the physician at Frederick Health. So let's have Dr. Casiano start.
Good morning, everyone. Thanks for having me here. As was mentioned earlier, my background is clinical medicine. I'm a general surgeon by training, practiced here for about 23 years in private practice, and then started, after my Hood MBA, started working for the hospital in an administrative role, and have been chief medical officer now for 13 years. So my interest is really quite clinical. I find the science fascinating, but I am not at all qualified to get into the basic science of this like Dr. Pittman, Dr. Brookmyer could. I'm much more interested in how do we take care of patients, how do we use testing to our best advantage, how do we seek out parts of our population who, for whatever reason, seem to be more susceptible to this disease. And really, most of my time now is focused on how do we get society running in a situation where it is, in my opinion, highly likely that COVID will be with us for the foreseeable future, just like influenza is with us. I hate to sound negative, but my feeling is that we're going to be living with this for a long time, at least for a year, and that's being optimistic that we'll come up with a highly effective vaccine, which in my opinion is still in question. So up to now, as Barbara showed you from the statistics, we saw a peak back a month, 6 weeks ago. We had really ramped up here in the hospital. We tripled our ICU capacity, doubled our regular bed capacity, cross-trained a whole bunch of nurses, doctors, and so on. And fortunately, the early efforts at flattening the curve actually worked very well here in Frederick. At our maximum, we used about 2/3 of our ICU capacity and less than half of our ventilator capacity. So we survived the initial surge fairly well here in Frederick. Currently, we have between 3 and 5 COVID positive patients in the hospital. We peaked at close to 40 at the peak. So I think we've handled things well. What keeps me up at night is worrying that we are going to all go back to normal pre-COVID behavior too quickly. Mm-hmm. I think we've learned a lot of valuable lessons if we can remember them and continue them into the future. I think masks are going to be with us. I think hand hygiene, I think physical distancing, all of those things are going to be with us for the foreseeable future. But I'm confident that with those things, we can control, probably not eliminate, but control COVID. Specifically, and I guess this would be my upbeat assessment here. I assume most of you know, but there's really two kinds of testing for COVID. There's the nasal swab, sometimes saliva, sometimes oral swabs, but all of those are PCR tests, and they look for the acute virus. They look for pieces of the virus, the presumption being that you're actively infected. There's also antibody testing, which looks to see if you've had an immune response, and therefore have you had at some point been exposed and developed an immune response to the coronavirus. We're doing both through the hospital. We've done about 26,000 PCR tests. At one point, they were as high as 28, 29% positive. We're down now in the 6% range for the acute swabs. And we've done about 1,600 antibody tests, 1,300 of those on our own employees, and about 300 on folks from the community, either from private offices, from employers, or just from folks who were concerned and wanted to know if they'd been exposed. The optimistic thing here is that for our own employees, of those 1,300 we've tested, and we've tested pretty much all of our folks who had frontline contact with COVID patients, of those 1,300, about 2.1% show antibodies. And when we do the tracing, about 2/3 of those got exposed outside the hospital. So my take home from that is, with proper precautions, which fortunately we implemented fairly early, the contagion rate is relatively low, certainly higher than a lot of other things, but it's something you can protect yourself against. What we're seeing on the country-wise, the 300 folks from the community are running almost 9% positive on the antibody tests. So with proper precautions, you can keep the numbers pretty low. And out in the community is probably your higher risk even than in the hospital, where we're pretty fastidious about our protections. So I'll stop there for the moment. Happy to go on with questions or so on. But as I say, my major focus is how do we keep prepared for a possible resurgence as we get into the fall, and how do we sort of set ourselves up so that we don't have to totally shut down our community, but still can be safe.
Excellent. Thank you so much. Dr. Pittman, let's have you provide your opening remarks. And we do have a lot of questions about immunity and things like that. So let's have you provide your opening remarks.
Thank you very much. Glad to be able to join this distinguished hood group today. SARS, coronavirus 2, the causative agent of COVID-19 pandemic, emerged from an animal reservoir in the fall of 2019 to cause the worst pandemic known to this planet since the 1918 pandemic. Until 20 years ago, with the rise of SARS, coronaviruses were thought of as inconsequential disease phenotypes expressed primarily as the common cold. Coronaviruses or enveloped positive strain RNA viruses. 4 human coronaviruses are endemic worldwide and are responsible for up to 30% of upper respiratory tract infections. Although coronaviruses can be isolated from a variety of mammals, the greatest variety of these viruses are seen in bats. According to Paulus, pure domestic mammals may serve as intermediate hosts, facilitating recombination and mutation events with expansion of genetic diversity of this important virus. The spike glycoprotein is thought to be critical for the binding to host cell receptors and may play a role in determining host range restriction, according to Dewey. SARS coronavirus 2 is the third coronavirus to emerge and make the jump from animal to humans within the past 20 years. The natural reservoir for all 3 of these recent coronaviruses is the bat. Although for MERS, coronavirus transmission to humans is attributed to an intermediate host, the dromedary camel. Common symptoms of SARS include fever, cough, shortness of breath, and occasional watery diarrhea, loss of taste, etc. And we will go through all of those. 10 to 30% of patients require mechanical ventilation, and up to 10% may die. Death rates, as we know, are much higher in the elderly and those with comorbidities. The predominant receptor appears to be human angiotensin converting enzyme 2, found primarily in the lower respiratory tract rather than in the upper airway. This receptor distribution may account for the dearth of upper respiratory tract symptoms that we see in individuals with COVID-19. MERS shares several clinical features with SARS, including severe atypical pneumonia, but there are significant differences. Patients with MERS have significant gastrointestinal symptoms and often acute kidney failure. These are likely explained by binding of the MERS coronavirus S-glycoprotein to peptidoglycopeptidase 4, which is present in the lower airway as well as the GI tract and kidney. So we can see a trend with respect to binding and where disease is mostly located. MERS requires mechanical ventilation in 50 to 89% of patients and has a case fatality rate of 39%. This is not to the virus's advantage in terms of long-term survival to kill a host at this particular level. The development of effective vaccines have been responsible for the control of several infectious diseases and the elimination of one viral infectious disease, which was responsible for several 100 million deaths over several centuries worldwide, and that disease is smallpox. The World Health Organization ruled smallpox eliminated in 1980. Nucleic acid platforms seem to be the favorite approach for the development of vaccines against the SARS viruses, including DNA vaccines, RNA vaccines, component vaccines, killed virus vaccines have been used for other agents. The vaccine for which we've heard most about recently is an mRNA vaccine developed by Moderna. The results of the phase 1 trial was reported a day or so ago in the New England Journal of Medicine, technically yesterday, and it showed modest promise. There were 3 doses, 25 micrograms, 100 micrograms, 250 micrograms. The immune response and of course, the adverse event response were definitely along a dose responsive pattern. There was great binding antibodies as detected by ELISA. Neutralizing antibodies were less impressive. Phase 2 and 3 trials are planned using the 100 microgram doses. So what other approaches are being made? Well, there are antivirals, including remdesivir, as we know, that shows some progress in terms of shortening hospitalization. This is an RNA polymerase inhibitor. There's also leponavir, ritonavir, interferon beta. These were started as therapies for MERS, but since they're similar, they are still being researched for COVID-19, are repurposed for COVID-19. Dexamethasone, which has long been in our medical armamentarium, is also being repurposed and seems to have significant benefits. Does infection with COVID-19 provide long life protection, or is COVID-19 similar to its common cold cousins? The jury is still out on this, but we do know that neutralizing antibodies are produced in some individuals. And we also know that the duration in some individuals are months rather than years. And of course, it's too early to determine the lifelong lasting aspect of these, although I think that we probably know the answer to that. Convalescent plasma or convalescent immune globulins have had a long history as used as therapeutics for infectious diseases, both viral and bacterial, for many, many, many years, at least since the 19th century for certain diseases. More recently, monoclonal antibodies have been developed for a variety of infectious diseases and can be used singularly or in a cocktail of monoclonal antibodies. And these are being looked at. Several hundred unique monoclonal antibodies have been discovered, and each will require significant research before they can be deemed as being effective in the treatment for this disease.
Dr. Pittman, I'd like to just interrupt you right there, and so that we're already half hour into the program, and I want to make sure we have time to answer a few questions. Would that be okay?
That is superb, because I can talk on and on.
I understand, yes. And most of our audience is non-medical professionals, so it's very interesting to understand, how this all plays out in terms of the pathophysiology of the disease process. But let me go back to, let me start with a few of the questions, because we have probably more questions than we can answer. But would one of you be willing to just answer a question about how does the immune system fight the coronavirus? And it seems like the virus is much more virulent than perhaps the common cold. So why is that? Which one of you would like to take that question?
Okay, I can take a stab at it, and others can feel free to join in. Well, there are two basic parts to the immune system, and that is the humoral immune system, i.e. the antibody size, and cellular immune system. And both are generally involved in fighting viral type of infections. So that is the reason why we generally measure the body's ability to fight infection by looking at antibodies. And these are proteins produced by B cells. It's a certain type of immune cell called the B cell, called B cells. So these are produced by B cells and are able to help to fight the infection. And of course, the T cells, or the cellular aspect of the immune system, we do not routinely measure, but it is measurable. And so that in some cases, even though there may not be antibodies or a few antibodies, it does not mean that one is not necessarily protected because of the cellular component. Now, when any virus emerges from the animal kingdom to infect humans, or any infection for which a human population hasn't seen before, that particular population is more susceptible. And of course, this is quite similar to the native populations when European settlers came in, bringing with them, smallpox, measles, the flu, and the common cold. So those populations were devastated. And it is because they did not have what is called any degree of so-called innate immunity, and there had not been the usual type of defenses over many years by the population becoming protective because of repeated bouts of infection with a particular pathogen.
Okay. Dr. Brookmyer, I think you were going to have a few comments about that.
Yeah, so I think in responding to the question of, what makes this so, so concerning and what makes this different from others. So while there are hundreds of respiratory viruses out there, and as was mentioned, there are other coronaviruses, 4 of them go by the name of the common cold. What's different about this is what it's triggering in our body, in our immune system. So instead of, say, maybe just having a sneeze or having no symptoms, in some people, their immune system appears to be turned on and sort of overstimulated and having an excessive response beyond what is needed. And it ends up impacting that overactive part of the cascade of immune system response impacts our whole body. So not just where the virus might be, not just where the virus particles might be. And that's where I believe we're experiencing complications previously not experienced when people have had exposure to the other coronaviruses referred to as the common cold.
I see. Okay, great. Thinking about our immune system, is there a way for us to boost our immune systems to provide us with feasibly more protection?
Yeah, can I just answer this one for everybody?
Oh, sure.
I mean, other people certainly chime in, but there is nothing at this point that has been proven to be as effective at reducing the potential for infection and illness than physical distancing.
Okay.
If people need to be in the presence of others who have been out and about or come in contact with items that are potentially contaminated, then the next best thing is good hand hygiene. So if you've potentially touched something that's contaminated, and if you're out and about, I would consider everything to be contaminated. So this is where people who would be self-described germaphobes, they're already ahead of us because this is their daily world.
Sure.
Pre-COVID is like what we're all being introduced to now and trying to think about. And then face coverings. So the best we can do if we have to be out and about with others is to try to reduce the potential to come in contact with the respiratory secretions of others. And so when we talk, they're very small micron size particles that are coming out of our mouths that we don't see, and that there's some very good photography efforts that can show when we talk how much stuff is actually coming out. I was surprised. I know that occasionally I'm a spitter when I talk, and so that I can see, but they're actually finer particles. And so the face coverings, while somebody wearing less than an N95 respirator, it's not catching all of what's coming out of someone's mouth, but it certainly helps to reduce how far the particles coming out of our mouths when we talk, and especially if we shout. And so the purpose for wearing the face coverings is to try to protect others from our spray when we talk. And, it's still an area of active research. How long does it stay in the air? We're hopeful that most of what comes out are considered droplet size, respiratory droplets, which are relatively heavy and then settle down due to gravity. There is, from looking at the case investigations and contact tracing, it appears as though the virus in our respiratory secretions aren't hanging out in the air as long as, say, something like measles, where for measles, it can linger in the air for 5-6 hours after somebody was in the room. So it seems, in most cases, it's a much shorter time than that, but it does make us concerned about time and space. And so that's why these recommendations are related to putting physical distance so that we're less likely to come in contact with someone's respiratory secretions, and putting the barriers. So it's a multi-layered approach. Every effort that we have to control the spread is imperfect. And so we're just trying to layer one layer on top of another so that we have better protection, but no one's safe. It's just a matter of trying to reduce the potential for exposure and reduce. And then, so once exposed, then I guess your question really was, what can you do to have your immune system be boosted? But the general things of get restorative sleep every night, have a good diet, exercise regularly, and try to avoid becoming exposed. That's the single best thing you can do.
Excellent. So in terms of face coverings, one question we have is, what type of face covering is best for the average citizen, and can I reuse them?
I can take that one if you like.
Okay.
For the average citizen out in the community, a cloth face mask works perfectly fine. Alternatively, there are so-called isolation masks, which are essentially what surgeons would wear in an OR. They are not the N95s that Dr. Brookmyer just referred to, which are 95% plus or minus effective. So they may be 60, 70, 80%. But if both people are wearing those, it's quite protective. And there's good literature showing that simple cloth face masks reduce infectivity or infection rates significantly. So I would certainly endorse what Barbara mentioned, physical distancing, hand hygiene, and face masks as the best preventive treatment here.
Okay. The next question is, we've heard that sunlight is lethal to coronavirus. Is that a myth, or is that true? And if so, if it is true, why haven't we seen coronavirus die off? We're in the middle of the heat of summer and long daylight hours.
Well, UV light does kill the virus if the dose is high enough and long enough. It's not clear to me that casual walking outside is either high enough or long enough dose. And it's certainly proven throughout the South that being in the summer is not protective. We've seen that in the last few weeks. I think you're talking the difference between a lab experiment with a controlled UV light source and sunlight in normal life. 2 years from now, we'll have a much better idea of exactly how much protection does summer sun provide, but my guess is it's not going to be a whole lot.
Dr. Pittman?
I completely agree with that. And it appears that this virus is not related to its other cousins in that respect. And as we know, if we can look at Texas, we can look at Brazil and other parts of South America, and we know right away that simply does not appear to be true. Whereas, as a previous speaker just indicated, there's no doubt that in the laboratory situation we can certainly kill the virus with UV light, but there appears to be other factors involved here that we will discover over time, but we don't know at this particular point.
All right, thank you. The question is, what role should testing play at Hood College in terms of identifying asymptomatic people, and should we be testing everybody at the start of the term?
So if you want, I could start with that. I mean, you could. So everything, it's really, all of these measures we're taking are all layered approaches, because there's no one single best way, no one effective way, no one complete way to identify everyone who's positive at once. And so anytime we test somebody, so if we test somebody and they don't have symptoms, a negative result in the absence of symptoms makes it very difficult to interpret, because on the day that that test was taken, it could be that the person truly is not infected, and that's why the result was negative. It could be that the result was negative because the person was tested too early in their disease course for the test to come back as positive. It could be that tests came back as negative because of a laboratory issue, and there are laboratory quality issues, not in Frederick County, thankfully, but there are quality issues where people are getting negative results, but they really are positive. So it would give you information for that period of time, maybe a couple hours, a couple hours before somebody was tested. So it would potentially help to, also if people get the results and they get them timely enough, and then they take action based on the results, then potentially you could reduce a number of people being on campus who have an infection and are capable of spreading the infection at the time of arrival. But then the question is, well, how frequently would you retest? Because I could test negative today and be infected, but tomorrow my test would come back as positive. Right. So then the question is, what's the frequency? So if you came up with a frequency of testing, I don't know, every 5 days, then maybe that would give you reasonable time periods after the first couple weeks, then on an every 5 days, but that's really not practical. And even for the nursing homes, so the federal government and the state of Maryland have said for staff of nursing homes, they're on a weekly testing basis. And we expect that, but that's after they had an initial effort to get everybody tested to try to get everybody up to speed. So after a couple weeks, so it does have a purpose, a really limited purpose though. And given the slowdown in results nationwide, I'm not sure anybody would be able to get results back in time to really make it effective in decision making.
Okay, great. Thank you.
Linda, could I add a little to that?
Yes, please.
In terms of the asymptomatic, it's real. Here in the hospital, we test everyone being admitted, whether they have symptoms or not. And 40% of the patients that we test that we think have COVID, that's one group, and we're fairly successful at getting them. But of all of our positive COVID tests, 60% of them are on people we had no suspicion of COVID whatsoever and came in for other reasons, a broken leg, appendicitis,
right.
Whatever. So actually we're seeing more COVID positive patients admitted to the hospital asymptomatic from COVID symptoms than we are with any of the symptoms you'd expect to have for COVID. So extrapolate that out into your grocery store and Home Depot and your 4th of July, beach party. There's a lot of asymptomatic folks out there. And as Barbara said, the test will tell you with about a 30% error rate, depending on a whole series of factors, whether the person is infected at that moment, but it's not going to tell you a thing about 4 days later or a week later or 10 days later. So unless you're going to commit to what, in my opinion, is a somewhat miserable test down your nose, every few days, the utility is somewhat limited.
Okay.
So that's the story on asymptomatic. The total opposite is symptomatic. And there, what you're really counting on is anyone with any of the whole list of symptoms rapidly self-isolating and rapidly getting tested so that you can start to do contact tracing. If you can get that part nailed down, you've got a much better chance of controlling this, in my opinion.
Okay, great. Dr. Pittman, I saw that you maybe had a comment.
Sure. agree with the previous speakers. Also, in terms of whether or not, for an institution of higher learning, and of course what some other institutes that sort of put themselves into a bubble do, is to before they enter the institute or the building or whatever, to have the individuals undergo a questionnaire with respect to symptoms and to take their temperature.
Yes.
And if either is positive, to send them back and or do testing. And that seems to work fairly well as opposed to sort of testing at an indeterminate number of days, repeatedly. This is going to be a very difficult and trying time, deciding the best way to manage bringing students and faculty and workers back to institutions of higher learning. And I certainly don't envy that particular decision. But what we're doing, of course, is monitoring for symptoms and then deciding on testing and sending home and et cetera, et cetera.
Right. Great. Thank you.
Just to add a little commentary to that, we in the hospital have been doing exactly what Dr. Pittman mentioned for the past 6 weeks of testing everyone coming in with a questionnaire for symptoms and taking their temperatures. The symptom part has been very useful and mostly for keeping folks home who are having any kind of symptoms. The taking the temperature part has been essentially worthless in the sense that out of the many tens of thousands of screenings we've done, we've had perhaps a dozen elevated temperatures and 0% of those have had positive COVID.
Okay.
So it makes you feel good. I really think the emphasis has to be on symptoms and on protection, whether or not you have symptoms.
Okay. Another
And
question.
send home if
Oh.
there are symptoms. No.
Another
I'm sorry,
question.
and send home if
Yeah.
there are symptoms. Yeah.
The next question has to do with the pneumonia vaccine. Interesting. Have health experts changed or updated their recommendations for who should get the pneumonia vaccine? And would this vaccine help with health outcomes if COVID-19 is contracted?
The answer is no one has changed their recommendations. That's the answer to the first part. The answer to the second part is interesting, and perhaps in a couple of years we'll know that answer. I don't think anyone has any clue at this point whether Pneumovax will help, hinder, or anything as regards COVID.
Okay. Can we address whether a full 14-day quarantine is recommended if an employee travels out of state for personal travel?
Okay, so that sounds like a public health measure one. It all depends, right? It depends what somebody's exposure has been. If somebody drove in their own personal vehicle and they stopped for gas but didn't go inside the place, they used a barrier protection for their hand when touching the pump stuff. If they wore a face covering, if there was no one else at the pump next to them with the wind blowing their direction, and then they went to a house and they made sure to wash their hands, never touch their face, eyes, and all that, and they stayed in the house, then maybe that's not a risk. But if they went to a place and they went out and mixed up with other people, they went to a restaurant, they went to a bar, they went to an entertainment venue, had contact with other people, then their risk increases. If the prevalence rate of the virus is greater in that other location, then they have a greater chance of having been infected. At this point, though, in Maryland, there are no specific quarantine orders for persons coming back. But I would say, as a general precaution, if somebody has gone to to an area where there's a high prevalence, and even if they didn't go to an area that has a high prevalence, but they engaged in high risk activities, which we've talked about already, then it would be best for them to stay at their home quarantined for a 14-day period after their last exposure. But we realize that's not practical and that's not going to be happening. So that makes it even more important for all of us to assume everyone we have interactions with, assume that they're potentially infectious and asymptomatic, potentially infectious and it's the 2 days before their symptoms develop, or they are potentially infectious and they know they have a positive result and they don't care anyway, or they don't have the luxury to be able to do something other than be out and about with folks.
Okay. A hypothetical question, which we may not have an answer to from you all, but if I have been, if I'll use myself, okay, if I have been practicing all of these measures, physical distancing, hand hygiene, wearing a face covering, and really limiting my exposure to people, and I haven't contracted the virus in the last 4 months, if I continue practicing all of these things religiously, do you think my risk for contracting the virus will be limited? I know that's a hard question to answer, but it's one people are asking.
Your risk will be low, but not zero.
Right.
Your risk will be lower than someone who goes out and has a big bar party indoors with a whole bunch of, their 200 closest friends.
Right.
Exactly what is that risk? I don't think anyone knows.
Okay. We're just about out of time. Another question is, what drugs are being administered to patients in Frederick County who present with severe COVID-19 symptoms and are hospitalized? And how effective has this treatment been for these patients?
I can attack that one. We've used remdesivir, we've used convalescent plasma, we've used hydroxychloroquine. Basically anything that's been mentioned, we've tried, and we've been underwhelmed at this point that any of them make a huge difference, at least in terms of things like mortality, preventing ICU, preventing intubation.
Okay.
It's going to take large-scale studies to know, for example, how effective remdesivir is at decreasing length of stay, but we have not been impressed overall at this point, which is another reason why I said at the beginning, I think we're going to be living with COVID for quite some time, because I don't see any curative agents on the horizon anytime soon.
Okay. Next question is, I heard that there are blood types that are more susceptible to the virus. Is that true?
It's probably true and probably irrelevant, in the sense that, a few percent one way or another tells you nothing about you individually.
Right, and we can't control our blood type. That's an uncontrollable factor. Yes. Dr. Pittman, did you have a comment?
No, I agree with that, but for those who want to know what the discussion is about blood types, it is thought by some that blood type A seems to put one at more risk for getting disease and for more severe disease, and that blood type O tends to have low risk and have less severe disease. But as we've all said, what the difference does it make? And chances are it is not, just the blood type itself. That there's likely to be other risk factors or covariants that are playing a role here. So,
great.
and of course, there's you can't do anything about blood types. I agree with all of the previous comments.
Well, we are at the conclusion of our time allotment. So let me just summarize, I guess, what I have learned and reinforced in my mind. And of course, I'm a nurse, so I have a perspective on this. But I think one of the things that I learn is, and know, is that this virus, this pandemic, requires each of us to have a measure of civic responsibility and integrity as to monitoring ourselves, practicing what we know helps spread the virus, and being responsible citizens. Even though it can be difficult, it can be a depressing time, in the end, we'll all be better off. And it gives me great pleasure that we've had this time to talk, and I'm sure we could talk for hours about this. So I'd like to thank our panelists and everybody that sent in questions. And Carol, I'll turn it back over to you.
Thank you, Linda. And I want to thank our esteemed panelists for spending time with us today. I'm afraid we're probably going to get a lot of requests to bring you back. I hope that you will be open to that. So again, we all want to encourage one another to do what we can to protect ourselves and one another. And we look forward to continuing on this learning journey so that we can help others in our community as well. So thank you all for participating.
All right, take care, everybody, and stay well.
Mm-hmm.